Welcome, everyone. This is Dr. Eugene On, medical oncologist at CTCA Chicago and co-chair of the SIO Communications Committee, and I'm happy to host and moderate this SIO monthly webinar, and thank you for participating with us today. As a reminder, this webinar will be recorded and posted on the SIO YouTube channel for your reference in case you're having any bad connections or have to leave early. Also, I would remind the audience that if you have any questions for the presenters, please send them through the Q&A box icon at the bottom of the Zoom webinar screen located in the toolbar. If you put your question in that Q&A box, I will review those questions and ask those questions to our speakers at the end of this presentation. You can also use the chat box to contact us, the organizers, directly if you're having any technical difficulties. And also, as a plug for upcoming SIO monthly webinars, I just want to mention that our next webinar will be on May 17th with Dr. Anthony Bosses talking about psilocybin for existential distress for cancer survivors. And we'll have Dr. Scout and Pratt Chapman, well-known leaders in this area of research, presenting on LGBTQ equity and cancer care on June 16th. So follow us on Integrative Onc at Twitter or on LinkedIn, Facebook, or Instagram for our latest announcements of SIO online content. And so now I'd like to introduce our speaker. So our first speaker is Matthew Weitzman. He's a licensed acupuncturist and the acupuncture team lead of Memorial Sloan Kettering's Integrative Medicine Service. And as an oncology acupuncturist, Matthew is active in research, education, and clinical care to advance the science of acupuncture and help alleviate the suffering of people with cancer. He will be reviewing the literature and trials to show us distinct benefits in patients with cancer. So without much further ado, let Matthew start.
Thank you, Eugene. Thank you to SIO for the invitation to speak here. Not only the acupuncture team lead, but I'm also the co-chair of the Acupuncture SIG. For all you acupuncturists who may not be involved, please check this out. We'd love to have you over there. So today I'm going to be talking about moving the needle on cancer pain management and building the evidence base. And primarily I'm going to be talking about two really exciting trials that are currently underway at Memorial Sloan Kettering. One is called the MPACT trial with a PI of Dr. Jun Mao, who's the service chief at the Integrative Medicine Center here. And this study is looking at integrative medicine for pain in patients with advanced cancer. And this trial is really important as this is a really understudied population. For this status quo has often been just pharmacological management of pain. And here in this trial, we're comparing acupuncture and massage to see which one has more benefit for patients in this population. The second trial that I'm going to go over is called the Optimal High Chemo trial. And this is led by Dr. Gary Deng, who's the medical director here at Memorial Sloan Kettering's Integrative Medicine Service. And this is opioid-sparing pain treatment in myeloma and lymphoma patients undergoing high-dose stem cell transplant. And high-dose chemotherapy and stem cell transplant. So I'll get into a little bit about that population and why this is so important. This research is so important to find alternate pain management strategies for these patients. So some background as to why we're doing these kinds of research. So a number of societies have released with their guidelines the recommendation for physicians to include non-pharmacological interventions such as acupuncture and massage in conjunction with drugs for pain management. So this is, of course, on the backdrop of a national opioid epidemic. And this population, especially with patients living longer and often having a high symptom burden, it's really important to find other strategies to manage their pain rather than opiates and other pharmacological strategies. And both of these trials are funded by PCORI, or the Patient-Centered Outcome Research Institute. And I just want to speak a moment about this because it really makes it an amazing process that really centers patients throughout the research process. So they were founded in 2010 with the mandate to improve the quality and relevance of evidence available to help patients, caregivers, clinicians, employers, insurers, and policymakers make better informed health decisions. In the process, a patient advisory, there are patient advisors who, from the very start of developing the research questions, are involved. and really take a pivotal role in this research that's done. So both of these trials are really patient-centered. It's exploring modalities that patients are interested in, and it's meeting a need that patients have. So the research questions for the MPACT trial that we're addressing are, first of all, which of the treatments, acupuncture or massage, is more effective for pain and comorbid symptoms in individuals living with advanced cancer? So that's the first question, the comparative effectiveness. And then, given my situation, which of the two treatments is better for treating pain in patients like me? So this is really patient-centered, precision-guided integrative medicine here, where we're looking at a patient-specific presentation, and based on this research, we're hoping to be able to guide them to one treatment or another that's going to have the most benefit for them. So the study design for the MPACT trial is it's a 2-arm parallel group randomized controlled trial. So among 300 patients living with advanced cancer who are experiencing moderate to severe pain, they'd be randomized to one of 2 groups, either receiving massage for up to 10 sessions over 10 weeks or electroacupuncture for the same duration. So it's up to 10 weekly sessions for 10 weeks. And then there were 4 additional sessions once a month, kind of like a booster session. And we'd follow the patients throughout, providing surveys of their pain and other comorbid symptoms, such as their sleep quality, their fatigue level, anxiety, and stress and quality of life. And it's a 26-week study duration. These were the inclusion criteria. So patients 18 and older with advanced stage cancer. So for different diseases that had a different definition. They were functional patients, mostly able to take care of themselves, and they had an element of musculoskeletal pain. The pain was present for at least a month with an intensity of at least 4 and was present for 15 of the past 30 days. And again, we were looking at patients with a life expectancy of greater than 6 months. And this study builds on a study that was completed here a few years ago, published in JAMA Oncology in 2021, that compared electroacupuncture with a form of auricular acupuncture, referred to as battlefield acupuncture. This was in cancer survivors who had been at least 6 months NED, who were experiencing chronic pain. So here we did see in this population, compared to usual care, the electroacupuncture had a 1.9 point reduction in their pain scores compared to usual care, and auricular acupuncture had a 1.2 roughly point drop in their brief pain index. So it was quite significant, but again, this was for cancer survivors, and so we really haven't looked at addressing and really looked closely at these modalities in patients with advanced stage cancer. So the protocol intervention, so after the patients were screened, a primary area of pain was identified, and along with comorbidities such as fatigue, anxiety, depression, and insomnia. And these were assessed both by surveys and then by the therapist who was doing the intervention. And for patients who were randomized to the electroacupuncture group, the protocol called for 4 points in the area of the pain location, as long as there weren't any contraindications to needling in that site. And I'll get into that and some safety considerations in a little bit, as well as additional points to address those comorbidities that we noticed. And there was quite a bit of freedom for the acupuncturist to use their own clinical judgment and really assess what the best treatment would be for this patient. So in that way, it's a real world encounter, very pragmatic approach. And the needles, needle range was 10 to 20 needles total. Electric stimulation was applied and the needles were retained for 20 minutes. For patients who were randomized to the massage group, there was a 30-minute protocol done on these patients, and Started with parasympathetic toning to really calm their nervous system. And then they proceeded with some pretty gentle, superficial fascial release techniques to address the area where the patient was having the primary pain, as well as other related body systems that may be contributing to the pain or may be impacted as a result of the primary pain. And yeah, again, if in some cases there was a contraindication to doing local needling for some of these patients, in which case only distal points were used. And just in the way that an acupuncturist would approach any patient using a combination of a conventional history as well as their Chinese medicine diagnoses. So this was a population where we really needed to use a lot of cautions. They're very complex medical histories in many cases. So it was really essential to thoroughly review the medical history. And I just want to emphasize for any practitioners who are outside of academic institutions who are working with this population, communication with the primary team and having access to those up-to-date records is really crucial and important to maintain in case there are any changes in the patient status. It's really important to monitor patient comfort more closely, as they may be a bit more sensitive. And then there are a couple of acupuncture contraindications that we followed if the patient's platelets were below 20,000 or if the neutrophil count was below 0.5. And those were precautions that are standard in our institution to avoid any bleeding or infection complications. Other things to consider when approaching this population is the presence of any implanted devices, such as a Metaport, any prosthetic implants, a colostomy bag. All of these things you need to be aware of and make sure that you're giving a wide berth to with regards to any treatments. Any areas of known metastasis were avoided. Any areas of recent radiation, swelling, redness, open wounds or sores, and large surgical scars. And these were really, it was very important to just be mindful of this. And this was a difficult population to work with in some ways, in that often they're in the midst of treatments. They could be having a really hard week. It could be difficult for them to get into the clinic. So that's why it was up to 10 sessions for the 10 weeks, because we recognize that there are challenges that were unique to this population that prevent them from getting into the clinic. Not to mention that this trial started in fall of 2019. So we got through about 6 months and then we did have a bit of a disruption. And starting back up, it was a lot more challenging, especially in our Manhattan locations, for patients to get into the clinic to see us. But we did, thankfully, we do have this trial open in our regional sites, and many of the patients were a lot more comfortable in those satellite offices. So I just want to share a couple of stories from patients who went through this. And for the MPACT trial, we've actually just completed accrual. We're still finishing up with a few patients, but we're getting close to the data analysis. So stay tuned. I hope we have some exciting information to share in the coming months. This was a 41-year-old female with a history of metastatic breast cancer. Metastasized to the liver, spine, and hip. And she had done a number of rounds of chemotherapy, had radiation, and was on TDM1. Pre-diagnosis, she was a competitive athlete. She was a volleyball player. She had a very active lifestyle. She also had a very young child at home. And so, this pain was really slowing her down. The pain developed after radiation therapy to the right hip, and present about 6 months at the time that I started seeing her. And again, she was having a hard time keeping up with her young son and really staying active. And after our first session, her pain reduced down to 2 out of 10. And after 4 sessions, it completely resolved. So this was an amazing response. I think she was just absolutely thrilled with her response to the treatment. She was really able to get back to her life and really move on, which was wonderful for her. This was one of our massage patients early on. This was a 25-year-old male with a form of testicular cancer that had metastasized to his lungs, his brain, bone, and liver, and he'd been through a lot of difficult treatments, wedge resection, brain radiation, multiple lines of chemotherapy, and was having severe pain in his chest that was associated with coughing and ongoing nausea. And he was rating his worst pain at a 4 out of 6, and that was for the first 6 treatments. It then moved down to a 1 to 2 out of 10 for treatment 7 and 8, and for the remaining treatments, it was a 0 out of 10. And associated with that reduction in pain, his nausea improved, and his coughing also resolved. So this was a young man who hopefully has a long life ahead of him, and to be able to have strategies that can address his pain without reaching for pharmacological therapies is so valuable for him. So that was the MPACT trial. The other trial that I'm going to talk about is the optimal high chemo trial. So this is for patients undergoing high dose stem cell transplants. So if you're not familiar, this is a treatment that's given for patients with multiple myeloma and forms of lymphoma, where they're given, their stem cells are harvested and they're given a high dose chemotherapy that basically wipes out their blood cells, and then their stem cells are given back to them and re-engrafted and built up in a more healthy way. So it's a long process. Patients are often inpatient for about 30 days, and there's often a lot of high symptom burden. So I know I only have a few minutes to go, so I'm just gonna get through this trial. Skip through that. So this was another multi-center. This one is in collaboration with Fred Hutch Cancer Center out in Seattle, and it's a 2-arm parallel group, individual randomized trial. So we were comparing acupuncture plus usual care versus usual care alone. And in this case, usual care for pain in this population is opiates. So we're thinking about this as acupuncture as a first line with opiates as a backup. So no patients were denied standard of care opiate treatment during this. So they were randomized to one of the groups. In the acupuncture group, starting from the day of their high dose chemotherapy, they're given acupuncture every day, as long as their blood counts allow. So again, the ANC was above 0.5 and the platelets are above 20,000. So we usually get 5 or 6 days of treatment in, and then their counts drop off. And then somewhere around day 13 or 14, we might get another couple of sessions in. And these patients are then followed beyond the stem cell transplant for 30 and then 90 days. And just the eligibility criteria, I'm just going to skip over that. And this was developed after we had done a pilot trial a number of years ago comparing real acupuncture to sham acupuncture in the same population. And what we found was that patients who received real acupuncture were really able to flatten the curve of the symptom burden. It really holds potential to reduce polypharmacy and reduce the introduction of opiates, which when opiates are introduced, even for an acute pain, it really heightens the likelihood that the patient might grow a dependence to opiates, even when that acute pain is no longer present. And so that's reflected here in some of the data from our pilot trial, that when compared to the sham acupuncture, which is the red dotted line here, the true acupuncture group had a significantly lower pain and a significantly lower probability of becoming a new opiate user at day 90, beyond the acute situation. So I'll just share what the protocol is for this. So this was a standard set protocol that every patient received with the common symptoms of this procedure in mind. So it was Du-20, ear shenmen, yin tong, PC6, large intestine 4, stomach 36, spleen 6, kidney 3, and liver 3. And electric stimulation is introduced to spleen 6 and stomach 36. So we're addressing nausea and gastrointestinal complaints. We're addressing fatigue with this. We're addressing stress and anxiety. This, and of course, we're addressing pain. And this trial is about, we're almost 2 years into this trial, and we expect it to be another year or so of the intervention phase, and then we'll do the analysis. So as these trials are ongoing, I don't have any data to share, but we can, the hope is to then disseminate to clinicians and patients tools that can help them choose which of these therapies can be beneficial for them. We disseminate to therapists who are working with this population to understand safe ways to practice in this more vulnerable population. And we disseminate to influence policymakers and payers to improve access to effective non-pharmacological treatments for pain. And this is an element that requires a lot of help. And so I'll have Alec Stone, who's a lobbyist, speak more about that. So thank you. I look forward to your questions after Alec's talk.
All right, thank you, Matthew, for that interesting presentation. One thing, if you have any questions, just as a reminder, go to the Q&A icon at the bottom of your window, and you can ask any questions there, and we'll go over those at the end of this presentation. And I'd like to segue to our next speaker. Alec Stone is our ONS Public Affairs Director and has been a leader in healthcare, legislative, and regulatory affairs for more than 2 decades with an expertise in biomedical research and healthcare advocacy. Mr. Stone has worked with premier organizations such as the American Cancer Society and the American Medical Association, as well as corporations like GlaxoSmithKline and Pfizer. He also has extensive experience with Congress and federal health agencies, and he's created 2 congressional health caucuses and worked in the Clinton White House. He is immensely qualified to discuss how we can help advocate for coverage of integrative medicine services like acupuncture. And without much further ado, Alec.
Thank you, Dr. Ann. So first I have to give a shout out to 2 of my members who recommended me for this, Milagros in New York and Sanjita in San Francisco. And so I'm pleased to be able to present briefly today. And I want to sort of give a shout out again as well to the previous slide set and love the title, which talked about evidence-based, moving the needle in cancer pain management and being evidence-based. Those are 2 things that ONS really promotes, pain management and evidence-based practice. And we try to encompass evidence-based practice in all of our advocacy efforts. And we talk specifically about pain management in the cancer survivorship tract. And so I echo everything that's been said so far, and your roles as clinicians in this process makes it easier for advocates to carry the message to decision makers. And look, I don't really have to tell you, you read the newspaper, you see the news, you know what's going on. Maybe you're having an argument with your neighbor about the political environment, and you're on opposite sides of the political extremes. That's just how things go. And having been in Washington for 25 years, I used to joke and say, man, I remember the days when we got along so much better. It was wonderful. That was when, Gingrich was Speaker of the House and Clinton was the President of the United States. And in the 90s, that rhetoric was incredibly high. That is nothing compared to what we have now. And what happens is it leads to a level of dysfunction that does not allow us to move forward on major areas, particularly healthcare, as we try to advance. So I like to put this slide up. It sort of gives me some cover. I'm going to put my radio voice on now, and here I go. This presentation does not represent the endorsement or support of any political candidate, incumbent party ideology, or dogma. Information presented today is strictly for educational purposes, and we seek to inform the audience of ONS's policy positions under the current environment. You may see people on here you love, you may see people on here you hate. You should know that we as an organization, ONS, and I will dare say, any professional healthcare, medical practitioner organization, patient advocacy group in which you are a member or you are engaged is the same way. We are not partisan in our advances. but we are political in that we are working in that political environment. And I assure you, whether it's the AMA all the way down to any other group across, same thing. ONS, the American Nurses Association, the American Cancer Society, all of these groups work in this environment. We play the cards that we're dealt. We don't have any control over who is the speaker, who's the president, who has the majorities, but we do have the ability to maneuver in those environments. And so keep that in mind as you go forward in terms of the dysfunctionality. I often hear from my members and from other healthcare providers, and I've been doing this for 25 years in Washington, D.C., that we shouldn't be doing this. We don't have a right to do this. This isn't an area in which I'm comfortable, and that I certainly understand, or an area in which we should be engaged. That is incorrect. It is constitutionally incorrect. In fact, literally written in the Constitution is the right to petition your government. So if you want a street light at the end of your corner, or if you want to talk about funding for palliative care and palliative Care and Hospice Education Training Act. It's a bill that's passed the House 8 times and has languished in the Senate. You have every right as a citizen and certainly as a practitioner to ask your members of Congress, both in the House and in the Senate, and by the way, at the state legislature and at the local level as well, you have every constitutional right to petition your government for redress. And so don't think that you don't. ONS's agenda, which is very much like others in the cancer environment, is this at the 40,000-foot level: quality cancer care, patient and staff safety, workforce and education, value of oncology nurses, and scope of practice. And within each of these domains, we then drill down and get a little more granular as we talk about again, within scope of practice, waivers and education and safety issues, or if we're dealing with quality cancer measures at CMS, and certainly during the pandemic, public health issues, that is part of what we're doing. And we try to, as we say in Washington, swim in our lane. We don't talk about going to Mars. We don't talk about putting up a wall somewhere. We don't talk about other issues that are outside of our areas of expertise, which are, I like to say for ONS, we are the cancer experts in the nursing community. We are the nursing experts in the cancer community, and we are a valued partner in the overall healthcare community. Branding is very important, and it should be to all of you. Where you choose to advocate, you need to know the parameters there, and ONS tries to do that. Love this right here, Gallup poll, and I'll tell you, for 20 years in a row since 2002, actually since 2020 and maybe a little bit before that, although after 9/11 in 2001, firefighters moved up to be #1 trusted. But since that time, nurses have been the #1 public trusted profession, not healthcare profession, but profession in the United States for 2 decades in a row. And this says 84% positive rating, which really is slightly off. During COVID, that number has jumped up to 91% positive, most ethical and trusted profession. Medical physicians, pharmacists as well. I always like to tease a little bit. If you go down, you'll see who's at the bottom: telemarketers, car salespeople, and then under that, members of Congress. Okay, that's where the trust is these days. So if you're in the healthcare business, your level of trust and ethics has risen in the public eye and domain, particularly these last 2 years. However, half of the healthcare workers have said that they have felt defeated by the demands of their jobs. And again, I don't need to tell you what's it like being on the front lines and managing these days. There's a lot of talk about the Great Resignation. That's across jobs. But when you talk about healthcare providers, all of whom, no matter where you are on the spectrum, are on the front lines, particularly these last 2 years during COVID, you have stress, you have trauma, and you have burnout. And that is particularly evident in the nursing profession, where we're seeing people retire early, and taking travel nursing jobs that allow them to go different places that don't have the usual mechanisms of how they practice, and worse, lower rates and applications of people wanting to go into the nursing field. And that's a real issue here. You can see it's oftentimes they're saying they mostly cope with it. And I actually tend to know my members, and I'll tell you, they're putting on a brave face. I think that number is very high, that they're saying they're certainly able to cope with it, but I think it's taking a harder hit than they say. And that 50% really, and then there's another 23% who say they don't have an opinion, have felt defeated by the demands. Their ratios and lack of hiring and PPE issues early on, and just the time and the effort is really taking a drain. And that is everything has been driven these last 2 years through COVID. And when I say everything, I also mean the political and the financial, the economics that are involved, not only in healthcare, but in the entire American and global systems. And here you have a nurse say, I became a nurse because I want to help people. I don't want to watch them die these horrible, preventable deaths, shift after shift and year after year. I call it disinformation, despair, and death. This is really having an impact because there seems to be no end. And a lot of this is because there's disinformation and misinformation and calculated dis and misinformation out there promoting different kinds of adherence to public health issues that otherwise would not be the case. And that really is the issue when we talk about immunocompromised patients and COVID. COVID is bad enough as it is, but when you add a cancer diagnosis and the survivorship track to that, immunocompromised patients are really some of the most affected as you talk about adherences, because that means, oh, well, I've been told to keep socially distanced and not maybe leave my house and not go see a provider. And maybe, I should not go to the pharmacy, or I should certainly not go get screened. So if I do have a diagnosis and I'm on that regimen, I don't know what that means. So, it has pushed things off. And if I don't have a diagnosis, but I'm at a certain age, or I have a family history and I need to get those early preventions, screenings, then what we've seen from the American Cancer Society is that the trajectory over the next 2 years, you're going to see diagnoses found that directly correlate with that 24-month or however long this may go of people delaying their screenings and seeing higher rates at further down the line. And that's a problem. And why is that a problem? Well, of course, it's a health problem, but it's a public policy problem because it's also an economic problem. And that's what we're trying to talk about here. Vaccines and the process. ONS has been a big proponent of vaccines for a very long time. Think about HPVs. So when the FDA supercharged the process called emergency use authorization to get vaccines, to be put through the process and approved, that's where you got some of these real issues where people are saying, well, I don't trust it, and I'm not going to take it, and you can't put that on me. And I'll tell you that last week I was downtown in Washington, D.C. at a public health event, and the executive director of the American Public Health Association, APHA, said, look at this slide, you can see people are still saying, some people, that's how they track you. They're putting microchips in the vaccines. Look, public health employees are well aware that these are safe and effective vaccines, and we still have a large percentage of the American public who don't believe that and are not taking that. So again, adding that to immunocompromised patients, that's a big 1-2 punch. And then we've had this politicization of masking. The interesting thing is that 100 years ago, more than 100 years ago, 120 years ago for the flu, we didn't argue about public health issues. And when the public health community experts, providers, and practitioners talked about this, the rest of the country embraced it. former Senator, New York Senator Patrick Moynihan used to say, you're entitled to your own opinion, but you're not entitled to your own facts. And so, there is a level of politics involved in all of this, but oxygen is essential. And I will not wear your fear. And we don't co-parent with the government. This is putting other people at risk. And that's part of the issue as well. And it'll tell you right here, the public opinion survey tells you all of these issues are in the uprise in terms of disinformation. There was a time when we all used to get our news, and I'm sure it was biased, but not to the level that it is today from the nightly news. So it was, I'll date myself, Walter Cronkite or Tom Brokaw or Dan Rather. And I'm sure that there were biases within those broadcasts, but for the most part, they presented the news and they provided the experts. And now you see the top 15 issues that are a major problem for 2021. Disinformation is a major problem in society because whether you're liberal or conservative, you're doubling down on where you get your information. And that information, whether it's MSNBC or it's Fox News or choose anything else on either of those sides, you're not getting the full spectrum of unfiltered information. You're getting biases towards one political leaning or the other, and that has a real impact in how people behave, and that's the issue here at all. So much so that, and you're all familiar with the Surgeon General, Dr. Murthy here, who was the Surgeon General under the Obama administration and is back again. We all know that Surgeon Generals release reports on, on cancer and certainly on smoking and on a variety of public health issues. But his first report was unbelievable because it came out in 2021, about 6 months after he became the Surgeon General again. It was on misinformation. And the fact that he had to release a report on misinformation, and that misinformation, that false information, that inaccurate information, and that misleading information in and of itself is a public health crisis, was remarkable in the community. We have never had so many people disbelieve the public health community experts as we've had now, and that's based on politics. So quickly, I'll give you a quick civic lesson. You all remember, Schoolhouse Rock at the bottom there. I'm just a bill. Yes, I'm only a bill, and I'm sitting here on Capitol Hill. We have two equal parts of the government in terms of the legislative branch, which is the U.S. Congress. That is the House of Representatives and the United States Senate, and they are both elected. The House by population and the Senate, every state has, as you know, 2 senators, whether you're Rhode Island or you're California or Texas, and they send their representatives to the United States Capitol, and someone has an idea, and you bring that forward, and it goes through committee in each house separately, and then it comes together, the conference committee, and they have to hash out the verbiage, and I kid you not, both the House and the Senate, those bills, when they come to conference committee, have to match exactly down to the right comma in order to go back to their respective houses and then be voted on and then sent to the president. So that's where we are. What that means is that it's not sexy. Incrementalism is the best way to move good legislation forward. It's not sexy to be able to write a law that says, we're going to give everybody health care and that's how it's going to go. That's not how this works. We start by saying, let's cover all the children. Okay, let's cover seniors. All right, let's lower the age to 65 and let's raise the age to 21. Okay, we've done that for a while, but we see that we should probably do 55 and maybe 30. And then that's how legislation moves forward. It allows those hiccups that are either on purpose or inadvertent to be massaged and smoothed out in the process. And so incrementalism, not sexy, but is the best way to move legislation and good legislation forward. And it relies on a number of people and a number of tenets as you move forward. You've seen the House. There is a 6-vote margin in the House of Representatives. So every time Nancy Pelosi, the speaker, brings a piece of legislation to the floor, she has to be certain that there's a level of uncertainty there, that bill will pass. Because if 3 of her Democrats, and they could be either very liberal or very conservative, peel off and don't vote for a piece of legislation, then the Republicans have a majority in the House and that legislation fails. So she is in a way to maneuver in a sense, and it's very, very difficult to get anything through the House. Similarly, we're actually at a point in the Senate where you have a literal 50-50 split. We have 50 people caucusing with the Democrats and 50 people, senators caucusing with the Republicans. And so the only reason the Democrats are in the majority is because, as you well know, the president of the Senate is, that is correct, the vice president of the United States. And in this case, Kamala Harris has the deciding vote. And she then therefore gives them a 51-50 majority, and she will be doing many more tie-breaking votes as we move forward these couple of years until there's a shift in the balance one way or the other. But that is why anything that moves forward is either strictly on party lines without anybody in either party changing their votes, or hopefully it is bipartisan in order to move things forward. And when we're talking about these issues, we're talking about things like the financial impact that it has on cancer patients. And mostly what the American Cancer Society has said is that people, even with insurance, were unprepared for the cost burdens that fell upon them. 54% were unprepared, and 70% made significant changes to their own lifestyle. And many more than that had to go into debt. They had to sell their house. They had to run up their credit cards. They had to borrow money from family or friends. And it, of course, is disproportionate to women and people of color. And so overall, 73% said they are worried about affording the cost of their current and future cancer care. 73% of people said that they are worried about that. It's a huge impact. As I mentioned earlier, palliative care, this is a piece of legislation. It's passed the House bipartisan support with something like 432 of the 435 members in the House. And here are the issues it's dedicated. It has, because of politics, languished in the Senate. We are hopeful that this will move forward. Oral parity for cancer drugs, similarly, has also passed the House and languished in the Senate. This is to make cancer drugs, typically very expensive, to be equal to those that are given for intravenous drugs as well. And this is an access and affordability issue. And another bill for ONS is the lymphedema sleeve coverage, which puts the sleeve into a category of durable medical equipment, so that if you're 10 years old and you need one of these and you're on the playground for $100 and it tears or it's dirty and you still need one, it would be covered as you move forward. And that is a new concept as well, also passed the House and languished in the Senate. Generally, ONS and the community, here are a bunch of other areas that we do talk about. And as I talked about swimming in your lane, both for the profession and for the patient, mental health issues are beginning to top that list, and substance abuse as well. And so we tie these issues to cancer and cancer patients and survivorship, but we also talk about it, and you should all think about this and stand up in terms of being providers and practitioners of where your voice matters in all of these areas. And drug costs, of course, top the list of domestic policy issues across the board. 65% of voters say President Biden isn't doing enough, and 72% say that Congress isn't doing enough to lower these costs. And we can get into all sorts of discussions about importation and access and Medicare Part D and seniors, but it turns out that drug costs hit people the hardest because the out-of-pocket expenses that they don't expect as they move forward, even those people who have insurance coverage. And the top issues in terms of what national support is for healthcare are these areas: coverage for pre-existing conditions, think about cancer, expanding Medicaid in those states so that more people are covered, and as my kids like to say, coverage for dependents up until age and through age 26. And wherever you are in the political spectrum, everybody agrees that this should be in every policy there is out there. Finally, I'll say that ONS, I like to say, you can't spell ONS excuse me, you can't spell moonshot. I stepped on my own joke. You can't spell moonshot without ONS. Scribble it on a piece of paper, you'll see what I'm saying. We've been there 5 years ago from the beginning. And now with the relaunch, that's our CEO sitting next to Biden at Duke. That's our president standing next to the vice president. And that's ONS nurses in the White House with the vice president at the time. Because of Bo's experience through cancer, the vice president and now the president and first lady have an inside view of what cancer and that process is like. And so we're thrilled to be part of the relaunch and to be there in person. You can do so many things. You don't have to come to Washington, D.C. to stand on the steps and to quote unquote lobby your member of Congress. You can be and use your own, you can be a network and use your own network to leverage that change out there in the community. So don't think that, you have to do this in a way that you might not be comfortable. Trust me, you can do it that way. And we do it through a lot of coalitions like SIO and like with the American Cancer Society and like with the Patient Quality of Life Coalition or the nursing community or the Campaign for Tobacco-Free Kids. Many hands make for a light load, and coalitions are looking for experts like you who are practitioners and providers. So don't think your voice doesn't matter. It absolutely matters. We like to promote the nurses that are in Congress and go to them, and they carry the water for us. And we have wonderful relationships with the 3 nurses who are in Congress. And then finally, I'll tell you that we do bring 100 nurses, not the last 2 years, it's been virtual, but the 4 years before that, to Washington, D.C. to learn the legislative issues and to meet with their members of Congress on Capitol Hill. Everybody in this picture met with their United States House of Representatives and both their Senate offices. So we had 300 meetings in one day by 110 nurses who came to storm the castle, if you will. Your organizations do this as well, and I would encourage you to add your voice to that. I always like to end with this because it is the 202nd anniversary of Florence Nightingale, the birth of Florence Nightingale. And she said, and this resonates with nurses, and I'm sure it resonates, by the way, with all providers, rather 10 times die in the surf, heralding the way to a new world than stand idly on the shore. And that is actually what providers are doing. You are on the front lines, you are taking care of patients, but your voice matters in so many other areas. So my slides, I'm happy for them to be presented. This is my contact information, and that is my presentation. Happy to chat about if there are any questions. Thank you.
Thank you, Alec. That was a fantastic presentation as well. So we can now go into the Q&A. And so again, you can go to the Q&A icon at the bottom of your screen to ask any questions, but we'll go over the first one from Jody. This one's going to Matthew. And the question is, if CMS were to cover acupuncture for cancer-related pain, would demand for acupuncture rise? And are there enough oncology-trained acupuncturists to meet this demand?
Great question, Jody. We would definitely see an increase in demand. I mean, as Mr. Stone just talked about, cancer can be very expensive. So the more that's covered, the more patients will seek out this. And especially with the evidence base, I definitely think this would increase demand. There would probably not be enough oncology acupuncturists in some parts of the country. In some parts, there would be excellent coverage, I think, on the coasts and in some areas. But we are seeing more and more oncology included at major cancer centers. And with that is training for community acupuncturists. So I expect that training to grow in the coming years.
Great, thank you for that. And I'll ask a question to mix up the questions here. So my question is, Don Hirschman, representing the SWOG study group, showed clear benefit of acupuncture in the treatment of aromatase inhibitor arthralgias with significant differences over sham acupuncture and weightless control. What concrete steps can SIO and integrative medicine advocates do today to hasten financial coverage for acupuncture services for an indication like this? I think maybe that's a good one for Alec.
I was going to say for me. So make your voice heard ultimately. And that I would say if you're uncomfortable writing a letter to your member of Congress or United States Senator, which you shouldn't really be. They have staff in the congressional offices who field emails. So someone is reading it and they're actually reading it by law. That's part of their job. You may get a response. Hi, I'm an acupuncturist and I live in Manhattan and I work at Memorial Sloan Kettering, and here's my question. And why isn't this happening? And it would really be advantageous because it's patient-centered care, whatever you want to say. And you can go online and type in, who is my, if you don't know that it's Chuck Schumer and Kristen Gillibrand in New York, you can just Google who is my senator in my state, and that'll come up and it'll take you to their webpage, and you contact them. That's fine. But if you really, that's a little bit much, then go to your professional society, whatever that professional society is. I assure you they have someone like me. No, they have someone better than me who is there, who can help you navigate this. They're probably already talking about these issues anyway. And you can say, I'd love to join that conversation. And if they're not, you'd say, hey, you're the government affairs director for my professional society. Maybe you were unaware. This is something, and here, let me give you the quick facts on that. And that's how you can move forward.
Great. When I actually read one of your blogs, Alec, and you promoted the idea of maybe shifting attention to the federal level to the state level. Could you talk a little bit more about that?
Yeah, well, I'm glad. So one person's reading my blog. That's great. In difficult times, and this is not the first time this has happened, it's sort of, it undulates. When there's dysfunction at the federal level, there are wonderful opportunities at the state level. State legislatures are like incubators for federal law. Oftentimes, U.S. Congress will look to see, well, what's been done in these states? Well, wow, they passed this. Maybe we can pass something similar to that. It's not more difficult to find. You can type in who's my state legislator or who's my state senator. But this is the great part about that, is that your state representative will meet you for coffee at Starbucks or Dunkin' Donuts at 8 o'clock in the morning. And it's unlikely that necessarily you'll get to meet your member of Congress or Chuck Schumer at a Starbucks, the majority leader of the United States Senate. But I almost assure you that your state legislator will be eager to hear from you as a provider who lives in their district. And again, I can certainly help make those connections, but also your professional society can help you do that too. They are much more responsive and interested in that very local issue because they go to your soccer games, they go to the grocery store, they go to your church or synagogue, whatever you're doing, they're there, they're very interested. That is really local politics.
Great. And then another question from our audience for Mr. Stone. What type of legislation does ONS advocate for in terms of mental health concerns for onc nurses and people with cancer?
So social psych issues has been a priority for ONS for a very long time, and we've signed on to a lot of legislation over the last decade in terms of promoting that and access and affordability. Primarily, initially, I would say it was for the cancer patient to help in this journey of survivorship. But over the last 2 years, there's been much more emphasis across the healthcare field and the medical field about the provider. And I'll point to the Lorna Breen Act that passed 6 months ago, based on the physician who committed suicide under the pressures of COVID. And now we signed on to that. It passed. A number of, probably hundreds of physician, nursing, other provider groups signed on as well. And it provides money for mental health for providers as well as for patients. And so it's become a real issue, I think, across the board for provider groups to say, we need to weigh in on this. We're not, as a professional society, we're not only taking care of the patients, but of our own membership. So it's a huge priority.
Great. And we have a question on the chat board from Blake. He asks, are there currently any bills introduced into legislation that we should be monitoring or writing to our members of Congress to request specific support on?
Again, I would say if on ONS's website, you can go to our website, there's a page that says make a difference, I think. And on there, we have, like every other organization, I keep saying, we have a board voted on agenda, 2-page agenda, and it tells you the areas in which we are involved. And it talks about current pieces of legislation which we're advocating for. So absolutely. And any of your professional organizations will have that same kind of thing.
If I
Yes,
could, there is an important bill working its way through for, as many of you know, acupuncture is now covered as part of Medicare under certain circumstances. HR 4803, I see it in the chat here. And that's a really important bill to get acupuncturists covered under Medicare so that they can start providing that service.
Great. And I guess we have 5 more minutes, but I'll finish with one last question for me. One of the criticisms that I've seen in the literature as far as economic reimbursement for acupuncture is that we haven't done enough studies designed to show economic impact and agreed upon cost of providing acupuncture. But I find this rather an unfair double standard, considering the much more lucrative pharma business rarely has that kind of request before they determine the cost of their drugs. So I just appreciate your comments on that criticism.
I'm going to let Matthew take that from a clinical standpoint before I rally the troops on, advocacy and all those areas you just talked about.
Sure. Well, I mean, there certainly has been cost-benefit analysis done looking at acupuncture versus opiates, for example, for pain management. And in this case, there's so many unaccounted for costs of opiate use. And, with the case of acupuncture, you're really just paying for the acupuncturist. So I absolutely agree that it is an unfair double standard, and acupuncture has proven to be economically feasible.
In terms of what Matthew just said, I mean, we all agree that there is a national opioid epidemic that has happened. And so other avenues for patient-centered care should be available. And I'm sure you have enough research to present that. So, that's Washington is based on no, we can't do that. No, I'm not on the right committee. No, we don't have the finances to do that. How are you going to pay for that? And it's meant to initially knock people away who very easily. And so it doesn't always work this way, but the squeaky wheel gets the oil. And that's why a coordinated effort really makes a difference. So you bring the facts forward and you make a case. You find a champion on Capitol Hill or the state legislature, and you have them carry that and you maintain that relationship. I'll end with this. I speak a lot in cliches. This is a marathon. It's not a sprint. It's not a one-time thing. I sent that email and I said, we need to have coverage. Well, I'm done. That's great, but you're not done, and that won't make a difference. They want to hear from you. I'm not saying you threaten them. I'm saying you keep bringing that message forward because you are a trusted voice in this process.
Great. That's a great message to conclude on. So I don't see any more pending questions. So again, a lot of gratitude to Alec and Matthew spending their time to share this information with us. And again, welcome the rest of the audience to check out the video on YouTube, and hope to see you in future webinars. So wishing everyone well, and take care.